Mute. And this public workshop again is being recorded today. Thank you all for joining us. My name is Sheila Heflin-Connor, and I am the Policy Specialist and Supervisor over Hospital Services. I also have with me today Lori Cook, who is the Policy Specialist over Freestanding Birthing Centers, and Katie Day, who is the Policy Specialist and Supervisor over Physician Services. The purpose of today's workshop is to share the proposed policy updates to the Medicaid Services Manual Chapter 200 for Hospital Services and Chapter 600 Physician Services, and to solicit your feedback regarding these changes. And before we get started, just a couple of housekeeping rules. If you could please keep your phone or computer line muted at all times unless it is your turn to speak to ensure everyone can be heard. If you are on the phone, please do not put your call on hold. If you must accept another call, please hang up and rejoin us when you're able. If you are on the phone and have a question, you can hit the *5 to raise your hand and then the *5 again to unraise your hand. If you're joining us on Teams today, you can raise your hand by hovering over the smiling face with the hand icon on the top of your screen and then selecting the raise hand icon. And then to unraise your hand, just reselect that same button. The public workshop has been scheduled for 1 hour today, and due to scheduled events directly after this workshop, we will need to stick to the 1 hour window. So we are asking if everyone could please keep your comments or questions to a 2-minute window, please. If at the end of it, if we run out of time, if anybody still has additional comments, questions, concerns, etc., then you can feel free to email me and we'll make sure that we plug in my email address into the conversation box within this meeting. I'm going to go ahead and share our draft policy of the 200 first. Can everyone see the draft policy?
Yes.
Perfect, thank you. So you see here that we have the MSM Chapter 200, which is for hospital services. And throughout this chapter, we've made updates to anywhere where it indicated birth centers, and we've updated that to freestanding birthing centers. And that's in alignment of Assembly Bill 287, where birth centers and or obstetric centers were reworded to freestanding birthing centers. Bear with my scrolling. We have a couple minor changes that we're making to Section 201, which is our authority page. And again, they have to do with Assembly Bill 287, where it was birth centers, and we're now changing it to freestanding birthing centers, and or where it was obstetric center, and again, changing it to freestanding birthing centers. We have a CFR 42 CFR Part 440.255, which has to do with limited services available to certain aliens, or as we call it here at Medicaid, emergency Medicaid only, or EMO. We just added a descriptor there, as previously it just had the CFR with no descriptor of what it was in regards to. And then we roll into MSM 203D, which has to do with our NICU policy. And you can see here that we've removed InterQual and MCG and then added the full name of the Optum 360 Uniform Billing Editor. We are also redacting levels 3 and 4 are paid at the same rate due to the fluctuation of a newborn's health status. The reason for that removal of that sentence is because down here below the next sentence, already indicates that the newborn's highest level of care reached during a calendar day is what will be billed for and reimbursed. And then before I get into this part, I'm going to go ahead and scroll down. I have somebody who's not on mute. We're getting some feedback. Can you please mute your line? Thank you. So previously, back in February of 2020, this particular crosswalk for the UB editor, and which cross-referenced over to the InterQual and or MCG level of care, That was added back in February of 2020. That and the information that's related to it is all being redacted. Initially, we were going to totally just redact that information. However, after feedback from the hospital associations and some hospital representatives, it was decided to go ahead and add in this additional table. We still have within here each NICU revenue code that has the definition straight out of the UB editor. These are here on the 1, 2, 3, and 4, directly word for word. The descriptor for these revenue codes straight out of the Optum 360 UB editor. And then we're adding in this table, which has the revenue code and then the level of care. And it gives examples of the services or the medical needs for those infants as examples. And then we worked with some different entities to ensure that we were appropriately aligning the correct InterQual and or MCG level of care with those revenue codes. And then there's one for each of those. And then if we've gone over to the MSM 600, I'll go ahead and let Lori Cook explain the updates that we're making for that related to the birthing centers with AB 287. Lori?
Good afternoon. My name's Lori Cook, and I am the policy specialist for freestanding birth centers. Manual section 600 with specific language in 603.4, maternity care. We did update everything that had obstetric or just birth centers to the freestanding birthing center language. And as Sheila scrolls, you can see that again in the 603.4A, the stages of maternity care. Again, we removed the obstetric and we updated it to the freestanding birthing centers. And again, down here on number 2, removed obstetric and updated to freestanding birthing centers. And these were the only 2 sections in the 600 that we had to update.
And I'm sorry, Lori, I should have finished scrolling through the 200 for you first. So I'll go ahead and scroll through attachment A on that.
And attachment A, policy 0201, the header we had to change to freestanding birthing centers. And again, through the whole description and the policy revisions, you can see as indicated in red, how we added in the freestanding birthing centers, excuse me, and took out any reference to obstetrics, and it's just a language updates. And then down here under number 3, we did leave the Commission for Accreditation of Birth Centers as one of the accreditations that the organizations must still provide. However, we did remove these other accreditations as they're just a duplicate to the licensing process. And then under after number 4, 5, and 6 were memorandums of understandings that are no longer applicable, and we've removed those from just this manual section. And back to you, Ms. Sheila.
Thank you, Lori. And just to clarify one thing, it's not so much that the memorandums are now no longer applicable, it's that they're more of a licensing piece versus an enrollment piece with Nevada Medicaid. And with the passing of Assembly Bill 287, they are in the process of rewriting the NAC on that and updating language regarding those MOU requirements. And so since it is more of a licensing piece and not an enrollment piece with us, we decided to go ahead and remove those pieces.
Thank you, Sheila, for that clarification.
Of course. Thank you, Lori. And that is the overview of policy updates. I'm going to go ahead and turn it over to Dr. Caprero at this point in time, as she has some additional input that she would like to cover on the reasons for the policy update specifically to the MSM 203D on the NICU. Dr. Caprero?
Yes, thank you, Sheila. So before we take some public comments, I understand that there's a great deal of feedback about these proposed changes and the impact that they will have. And I just wanted to provide some historical information as to the reason why we're making these changes. So we're revising this policy in order to come into compliance with state and federal regulations. On May 17, 2019, there was an Assembly Committee on Ways and Means and a Senate Committee on Finance meeting. During that meeting, they approved a 25% increase on daily rates for certain Medicaid neonatal services. The level of care was approved by this committee with associated rates. So our changes in policy are consistent with those level of care and rate changes. If we were not to implement this policy, we would be subject to audit by CMS as well as LCB. So I just wanted to explain that the previous crosswalk incorrectly aligned with this legislatively approved clinical criteria and revenue codes. And so that's really the impetus to change this policy. I also did want to let everybody know that we have been in contact with the governor's office, and they're supportive of us in the go forward to this policy change, reviewing utilization data and reviewing any information that we might have about making NICU level 2 the 0172 rate changes in the future. But I just wanted to clarify for everyone that we're separating ourselves from the clinical criteria and the associated rates, and we're coming into alignment with what has been legislatively approved. Sheila, I'll turn it back to you.
Thank you, Dr. Caprero. And at this time, we will go ahead and open it up for any public comment. If you have any comment, if you could please raise your hands. Crystal, I see you have a hand raised there.
Good afternoon. My name is Patrick Kelly. I'm the CEO of the Nevada Hospital Association. And on behalf of the 12 member hospitals with neonatal intensive care units, we respectfully requested the state withdraw or substantially modify its proposed changes to MSM Chapter 200, Section 203D. The purpose of the changes was unclear to us until just a moment ago when the doctor spoke, but we find it unusual that the legislature would give us a 25% increase and then give us a substantial decrease at the same time through these changes. We don't think that matches up or meets the legislative intent. The practical effect of the proposed changes is a substantial rate cut for NICUs. And historically, we recognize that Medicaid doesn't pay the actual costs, but these changes are just too substantial cuts. The cost of caring for a frail and vulnerable baby is extremely expensive. NICUs require sophisticated technology, costly equipment, and large numbers of specially trained doctors and nurses. And this comes at a cost. And the new level at which we're going to be reimbursed for many of the services is just way too low. A Medicaid rate cut on NICUs is profound because more than half of our NICU babies are Medicaid beneficiaries. So we welcome and appreciate this opportunity to learn more about the proposed changes and to discuss it. And we look forward to working with you to come up with an equitable resolution. And I'd like to hold one of my minutes up till the end of the meeting. Thank you.
Thank you, and we appreciate that feedback. If I could just respond to that, I believe you were part of the MCAC meeting presentation this morning, and one of the slides for that, it had within it the different levels of care and the proposed rates, and all of those proposed rates versus those level of care were equivalent to what is being proposed in this new policy update. So I don't think it was the intention to give a 25% rate increase and then turn around and take something away. The policy that we are now implementing aligns with the criteria and definitions of those level of cares that were approved during that legislative session.
Well, thank you, but we'll have some experts follow up to kind of explain that a little bit more, because we're in a little bit of a disagreement on that.
Perfect, yeah, I appreciate that. And again, I will make sure I'm gonna plug in my email now into the chat. If you can send me anything you have on that. Crystal, I see you have another comment or question.
Yeah, go ahead.
Good afternoon. My name is Bill Ziesmer, and I'm the Chief Financial Officer at Sunrise Hospital in Las Vegas. You might be familiar with Sunrise. It's the largest acute care facility in the state and the largest Medicaid provider. In fact, 20% of Medicaid patients in Clark County receive care at Sunrise. We have the largest NICU at 72 beds with approximately 1,000 admissions per year. Medicaid is very important and impactful to us, as 89% of our NICU days are covered by Medicaid. Our NICU provides full service neonatal care, including ECMO for respiratory and cardiac needs. You may also be familiar with Every Baby Counts, which was a campaign that we had in 2018 and 2019 that highlighted the inadequate reimbursement for NICU care. And as was mentioned, the legislature responded with a 25% increase in 2020. So at Sunrise, my facility, this resulted in taking our NICU from a loss of 60 cents for every dollar of revenue collected to a loss of 30 cents for every dollar collected. So while we are still losing on every NICU day, it is a much lower loss than we experienced prior to the 25% increase. This proposed policy change and modification of the NICU crosswalk would have the impact of rolling back reimbursement to a level less than what we experienced prior to 2020, back in 2018 and 2019. Specifically, in the current policy, InterQual and Millman level 2 care is currently paid at revenue code 173. The revision in the policy revises that to pay it at revenue code 172, which is a reduction of $1,450 per patient day. This is extremely substantial for us. At Sunrise Hospital in our NICU, this is equivalent to $6 million per year of reimbursement. And at the 3 Las Vegas HCA facilities in Las Vegas, it is approximately $10 million. This is really at an inopportune time, as we are currently experiencing an unprecedented surge, both in volume increasing, combined with a shortage of nurses, where we are having to wrestle every day with how we're going to respond to that demand and how we're adequately going to care for our patients. So to have the prospect of revenue dropping precipitously at a time when demand and cost is rising with equal magnitude in the other direction puts us in a very awkward position. We do not want to revert back to the time in 2018 when we were trying to figure out how we were going to carve back the NICU services that we were offering. I feel this is a massive rate reduction that essentially reverses the decision of the legislature in 2019, where the intent was to move NICU reimbursement to something that was more adequate and appropriate. The impact, if we proceed, will be a reduction, if not elimination, of future investment in equipment and facilities needed to care for these babies, and will hinder our ability to staff and adequately support our NICUs. Secondly, this may result in a reduction of NICU beds available to NICU babies currently, and a lack of care, finally, for those who need it the most.
Thank you for that feedback. And I see our administrator, Suzanne Bierman, has her hand raised. So go ahead and call on her. See if she has a response for you or if it's something separate.
Hey, Sheila, I appreciate it. First, I just want to thank everyone for participating today and for the comments, and to just want to clarify and reiterate a couple of Sheila and Dr. Caprero's comments from earlier. One, want to clarify that this is not a rate reduction. Kind of the process that we would have to follow in the division for a rate reduction would be to amend our state plan amendment payment pages, and that's not what we're proposing here. Rather, what we're proposing here is providing additional guidance and guidelines around correct coding and just ensuring that the levels of care align with the billing codes. So still those higher levels of care are available for NICU babies that meet the higher levels of care. There are 4 levels outlined, and just wanted to clarify that this isn't about reducing any of those rates, levels 1 through 4 as outlined. It's just about appropriate coding for those 4 levels. So thanks, Sheila, and thanks everyone for your comments.
Thank you, Suzanne. And Crystal, I believe have another comment there or question?
I'll go next. Hi, good afternoon. My name is Jennifer Wakeham, and I'm the Chief Financial Officer for UMC. So just wanted to be here today. Thank you for allowing me to talk. We have a 36-bed NICU unit at UMC, and for the most part, we operate that at full capacity today. And so we get approximately 450 patients a year, and of those patients, 83% are Medicaid. So this policy change also has a negative impact on us to the tune of about $3.3 million annually. And at UMC, of course, our mission is to provide care to anybody that needs it, and we need to make the dollars go as far as we can, so that we can, live by our mission. I visited the NICU myself many times, and when you go there, seeing those little babies in the bassinets makes you realize why we're all in healthcare. To make the lives of others, better. And I, know my staff in the NICU. They're highly skilled, highly talented professionals, and they're very expensive. And honestly, any patient that is in the NICU, the nurse to patient ratio is very low. We oftentimes provide 1-to-1 care. Sometimes it's 1 to 2 patients, but again, it's a huge cost to us. And so I'm here to ask you to revisit that policy. So thank you.
We have another hand up. Is that right? Sheila, you are on mute.
Oh, sorry. Thank you, Crystal. Do we have any more comments there on your end?
Yes, we do. We have a couple of there.
Good afternoon, I'm Gary Smith. I'm representing Universal Health Services and Valley Health System. We operate NICUs in Summerlin Hospital, Centennial Hills, Henderson, and Spring Valley hospitals. Kind of changed my message here. First thing I want to get to the point is, even though you're communicating that there was not an intent to change the rate structure, in all practical purposes, it's exactly what you've done. Currently, our clinical level 2, which are intermediate care babies, are getting the NICU rate. By aligning it with Revenue Code 173 versus the current 170, aligning it with 172 versus the 172, the current 173, I'm sorry, it will reduce those rates. And so despite your intention, it's going to have a practical implication there. The removal of the crosswalk completely changes the proposal. And the information is right in the draft. If we're looking at section 203B, let's just look at 302.D.3. Above the box right there, it says revenue code 172 newborn, and this is the description from the Optum UB editor. If we look at the last line, it summarizes it. Considered to be continuing care. Now below that, the box, it says revenue code 172 newborn level 2, and then it has level 2 special care nursery neonatal intermediate care. And it has the clinical descriptions that go within that. Now, if we go down to item number 4, revenue code 173 newborn, get to the bottom of that, considered to be intermediate care. The description in 4 inside the box is neonatal intensive care. They don't match up. The UP editor descriptions and the clinical information that you put in here contradicts itself in the proposal. The current crosswalk lines up, and although it can be confusing, as I was stuttering through it myself just a few minutes ago, it's accurate. And so we need to make sure that that accuracy remains in place. If it doesn't, it's going to end up reducing our reimbursements, millions of dollars. And unfortunately, a few years back, Valley Health System had to make the tough decision to close the NICU at Valley Hospital. We used to have a NICU there. We're going to, hospitals in the state are going to have to take a hard look. And if we're losing reimbursement of millions of dollars, are these units viable? Can we keep them open? We expect to lose money. We know that. But the type of reimbursement that we're talking about, the funding to keep these cases open for the overwhelmingly Medicaid population is important. And if we lose that, then unfortunately all our organizations will eventually have to make business decisions. Is this a viable option? Do we keep it open? Or do we close it, limit services, reduce beds? So unfortunately, I really don't want us to have to get to that position. So I'm against this proposal. Thank you.
Thank you for those comments. We appreciate them. If I could just respond to a couple things on that. If I understood you correctly, you're saying that the prior table properly corresponded the UV editor revenue codes with the InterQual or MCG level of care. It was my understanding that the previous one did not match up, and we did work with numerous entities to ensure that what was on this proposed table for like a revenue code 173, that would equate to an InterQual or MCG level 3 and the 2 and so forth.
Excuse me, your proposal contradicts itself in here. So, I mean, if you look at the Optum UB editor and look at those descriptions for revenue code 173, it's continuing care. But the UB editor description for 173 is intermediate care. But the clinical description that you have under 172, that's your intermediate care. They're not lined up in this proposal. So I'm not sure where you're getting the information, but the policy here contradicts itself and demonstrates why it's wrong.
If you have a clinical information that you could send us, and again, my email is in the chat, that would explain why you feel it's differently, or any guidance that you have that would support your stand on it versus what we're proposing, because again, it was our interpretation, we ran it by other individuals, that these levels did truly match, and the previous table allowed for upcoding. And, you know, that was due to a previous agreement with DHCFE and the hospitals and the associations. But again, in 2019, when they approved the 25% rate increase for the different levels of revenue codes, they match up with what we have in here for these definitions for each revenue code. And possibly the confusion could be these are directly, where I'm highlighting here on my screen, these are directly word for word the definitions for the revenue codes out of the UB editor. Whereas here we received information that they would equate to these particular levels of care for the InterQual and or MCG. So we're happy to take a look at any information that you want to email us to see if there is any adjustments that need to be made in here. If I could also add from a policy perspective that we need to ensure that our policy is accurate, and again, that the prior InterQual and MCG levels did not correspond to our understanding accurately with the UB editor, and that it was allowing for babies to be upcoded to a higher level of care than what was actually being provided, and that with the new policy, our intent is to ensure that the appropriate levels of care correspond with the appropriate levels correspond with the level of care and or services that are provided, and in return that we're reimbursing at the appropriate level for those services that are provided. If we're not, and if we are allowing for upcoding under the prior, it puts us at risk of a CMS audit and the potential to have to refund federal dollars.
So I comment like a 30-second, probably less than 30 seconds. Sheila, I appreciate what you're saying. And I do think that we do need to highlight the segments that, because it's really hard verbally for, for us to communicate the pieces that appear to be in conflict, and we can color code those for you so you can see where they don't match. I really do think a follow-up, actually face-to-face, socially distanced kind of conversation would be really prudent in this circumstance, because I'm not quite sure all the experts that you've worked with on this, but as an industry, our industry sat down with the people in your chairs historically, including your medical leadership, and that's how we came up with the crosswalk that exists today. So I feel like that we're missing pieces, and the last piece I'll ask for is the piece you're referencing about that this is what was legislated. I don't ever remember seeing anything legislated that tied clinical levels of care to it. So I would really, if you guys could send that to the industry, that would be really helpful, so that we could share, because we obviously want the program to be in compliance. You know, our goal is not to have anybody be out of compliance. We just think that there's more to the conversation that should be had that we haven't been able to have with you yet. Thank you.
Thank you, Chris.
It's not a clinical dispute, it's just that the clinical components don't match up to the billing levels. And so it's just that, it's exactly that, the crosswalk. I'm not saying the clinical information is wrong. I think the clinical information in here is right for level 2, but level 2 doesn't match up to the description in revenue code 172. It matches up to revenue code 173.
Unfortunately, we're leaving out one of the most important components of the whole exercise, and that is that somebody in this state has some responsibility for providing and maintaining access and quality and level of care for the babies. And the fact that the indirect unintended consequence of your proposal leads to high reductions, almost certainly, in the access to care and the level of care is something you should not be dismissing. That's part of it. If you're going to solve a concern about the audit and a concern about compliance, then simultaneously you should solve the problem of access and quality. I am 100% certain that when those committees met, the last thing they ever intended was to have a rate reduction or a reduction of compensation at the level that you were talking about. And when one figures out what they meant to do and how this flows from that meeting in 2019, I think you ought to take that into consideration as well. The governor was happy to sign a document that had that increase in it. And so, I mean, this is just goes 100% against the intent of what they were trying to accomplish. I think you cannot ignore that factor.
Who are you? You never said who you were.
George Ross, contract for HCA.
Yeah, thank you, George. I recognize the face and the voice. Thank you.
I'll go next.
Thank you.
I'll go next. Good afternoon, members of the workshop. For the record, my name is Brian Clevin. I'm the Nevada Market Chief Financial Officer for Dignity Health St. Rose Dominican, representing all of our not-for-profit and for-profit entities in the greater Las Vegas area and state. I have to first echo the comments of my colleagues that have provided statements before me. The Neonatal Intensive Care Unit, or NICU, crosswalk was designed to allow for better transparency for levels of care and billing for one of the most complicated cases we see in a hospital, a baby in our neonatal intensive care unit. Because the patient's level of care can change frequently and without warning, it's important that hospitals are provided fair compensation based on appropriate standards for the care needs of those babies in our NICU units. The Optum 360 billing editor is purely a billing editor designed for the revenue codes. It does not match perfectly with the clinical care criterion of InterQual or say Milliman, as my colleagues have stated. It's not used, the Optum 360 billing editor is not used to determine a patient's level of care in any way. Removal of this reference or change of this reference misaligned with wrong revenue codes has substantial impact to the providers in this state, as you've heard before. It also worries me because managed care organizations would have basically zero accountability in how they determine reimbursement in paying us. It gives them basically free rein on it. Hospitals in Nevada are already burdened with extremely low Medicaid rates for all services, and this change affects a very vulnerable population. And as a mission-based organization, I have to re-echo that point. These are babies in our intensive care units. It's very important that we protect them. I would ask that there are no changes to the crosswalk at this time until you work with the providers, which is this group, on establishing appropriate changes that meets the need of Nevada Medicaid and the state and the Nevada Hospital Association and its memberships. We are the ones providing the care, so we can help educate the group and help guide it down an amicable solution for all parties. I think we need to continue transparency in this. I would also just like to say thank you for serving as state employees and public servants during a very difficult time. So thank you for all your hard work. I do believe we can get through this together. Thank you.
Thank you. We appreciate that comment and feedback as well. I can respond to one part, and I'm not sure if there's anybody else on the line that can maybe add some MCO, because that is not my expertise as far as the rates go. But you indicated how those babies, they can fluctuate and go up and down, which is why Nevada Medicaid does pay for the highest level of care that they were at within that particular calendar day to allow for those. So, and that is being left in our policy here, where it indicates the revenue code of newborn's highest level of care reached during a calendar day shall be billed by the hospital for that day. As far as, like the rates being too low, as a policy person, I don't have that the powers to change those rates. In my understanding, there has to be a whole legislature process in order to propose those additional rate increases. I don't know if we have Dr. Caprero or Suzanne can maybe speak to that, and or if there's somebody that can speak to the MCO part as far as disbursement rate.
That's the important point, and I don't know how we could say that this is not a rate item, because we are changing Milliman InterQual level 2 babies from 173 reimbursement to 172, and it's $1,400 per day. That is a huge rate issue.
It is, and again, it's my understanding that the prior table allowed for upcoding. And so we tried to look at this and say, what was the appropriate revenue code versus the InterQual code for those services that were provided? And this is the feedback that we, came.
But we weren't aware that it was upcoding.
You're using a term that tells me who you did talk to. It's
May I
not
speak?
upcoding to have the right level of care assigned to the right revenue code based on clinical criteria. And that's what InterQual and Milliman do. The right clinical care then routes to a proper revenue code for payment.
And I don't know how we can separate resolving a coding issue from the rate impact that it has. It seems to me that those two items should be solved simultaneously, not one done in 2020 in January, and then 2 years later, another adjustment that wipes that out and backs us up.
This is Alan Smith at St. Mary's. May I speak?
Yeah, Ellen, if you could hold for 1 second, please. I see that we have our administrator Suzanne's hand raised, so maybe she's wanting to respond to some of the comments so we don't lose track of everything.
Thank you.
Thank you, sir.
Actually, Sheila, this is Sandy. I'm one of the deputy administrators for the division. I oversee the managed care contracts. I just wanted to add that they are required by contract to follow our policy. So this change does not allow them to do anything different. And I know a couple of the plans are on the call. If they would like to comment, I do invite them to join in the discussion with us.
Thank you, Sandy. And Suzanne, I know your hand was raised as well. Did you have anything, or was Sandy able to answer that?
Yep, Sandy covered it. I was just going to point out that, they have to follow all of our policies. So, they're bound by contract to follow our policies. But Sandy made the point. So thank you, Sheila.
Okay, thank you.
Now may I speak?
Yes, please. Thank you for your patience.
Oh, thank you. You've done quite a good job monitoring this process, and I applaud you for this. This is a difficult topic, and you have a lot of providers that are going to be extremely negatively impacted by this decision. And so I think you've done a monumental job of keeping your cool. And I want to echo a few things, if I may. First of all, Chris Bossi mentioned that she could not see how MSN 200 and MSN 600 were aligned or needed to be aligned with Assembly Bill 287. So I respectfully request, because I just finished reading Assembly Bill 287 and cannot see any reference in that Assembly Bill that addresses the requirement that you need to revise MSN 200 or 600. So I am asking for material that would help us understand why that had to occur. That's one item. Secondly, on numerous occasions, you have referenced other entities, other experts, in regard to the qualification of this revised policy, that you have run it by numerous entities, unnamed, that you have heard from other entities regarding upcoding, again, unnamed. And I respectfully request, and if necessary, I can do so under the Freedom of Information, that we be given a full list of those that you collaborated with, if I may use that word, on the development of this policy. Regardless of the intent to align with 287, it is stated, the effective change, that there will be cost, that there may result in cost savings, definitely. quite a significant cost savings, affecting all the hospitals who provide NICU level of care tremendously. And so I disagree that the intent was not financially motivated, because I cannot see how this is out of alignment with Assembly Bill 287, nor can I see how this would be in violation of any audit conducted by CMS. And so I would also respectfully request that your specific concerns regarding CMS be stipulated so that we can follow up on that. That's basically all I wanted to ask for. Thank you.
Thank you. We appreciate those comments and requests. It was a lot, and I'm going to do my best to try to hit all of those highlights that you hit on. I think there may be a little bit of confusion. You're referencing the 287. The 287 doesn't have anything to do with the NICU policy updates that we're making. The 287, it's just we're doing the NICU policy and that language change per 287 all together. Anytime we have any policy updates, you know, it could be a vast variety of things, but we do them all at once. So on the 287, it was a bill that changed changing from obstetric centers or birthing centers to freestanding birthing centers. So it's strictly just a language change. It's just changing the names of obstetric centers and birth centers, excuse me, they're called birth centers, to freestanding birth centers. So that piece is totally not related to the NICU policy change. Our freestanding birthing centers, per our state plan, they are reimbursed one single code, and it's a all-inclusive bundled code for their services that they provide for labor and delivery and immediate postpartum care. So I hope that answers that piece. And then in regards to the entities that we worked with, it's not a secret and something that we were trying to withhold from you guys. We worked with our vendor, Gainwell Technology, because they have access to InterQual. And so Dr. Caprero and I kind of did research on different states, and, you know, we came up with these clinical examples within each section. And then Dr. Caprero also had Dr. States, I believe she's a pediatrician, a state pediatrician, correct me if I'm incorrect, Dr. Caprero. And then we did also run it by one of the MCOs because they have access to MCG. Neither of those does the DHCFP directly have access to. So those are the entities that we worked with in determining that what we had put here for the clinical information and the examples of care, that they would align with those particular levels of care. So I hope that helps to clarify that. And if you could please let me know if I missed any other piece.
Yes, and that's correct. That's Dr. Stade. She's our state pediatrician. She's with Department of Health and Human Services. And we did review other state documents in revising the level of care, adding more detail about the level of care. We specifically created this so that from the clinical perspective, when those InterQual and MCG levels change, the other clinical scenarios will provide enough level of detail and that this can still be correctly coded. If there is any other clinical information or other sources that you can point us to that have a different definition, we'd be happy to take a look at that. That's why we're coming to this workshop. We want to be open to any other information that you have as partners with us in this healthcare field. Our intent is not to create barriers to access to care. But again, I just want to reiterate that what we are bringing is clinical policy that aligns with a revenue code that's been legislatively approved, and that link to that joint Assembly Committee on Ways and Means and Senate Committee on Finance is in the chat. But I want to separate that from the rate discussion that we're having, which would be a separate discussion about how to increase the rates. Whether or not the rates fluctuate this policy would still, this alignment, correct alignment of revenue and level of care would, in our opinion, still be appropriate. But again, if you have other information to share with us, we're more than willing to review that.
Thank you, Dr. Caprero. And with that being said, we're down to about 9 minutes. And as indicated in the beginning, we do need to stick within the 1 hour due to other scheduled events directly after this meeting. I see, Sandy, that you still have your hand raised. Did you have an additional comment?
No, I don't. Thank you.
You bet. And Crystal, do you have additional comments there or questions?
Thank you. Thank you. This is Chris Bossi with Renowned Health for the record. I do appreciate the clarification just provided and recognize that whatever happened legislatively related to the fees connected to the revenue codes, this policy change was not part of the legislative intent, and the financial result of this policy change would absolutely, I don't believe, unless someone can help me see it, show me something different, was absolutely not considered when the rate increase went into effect. So we will, we are owing you the piece that Gary was referring to. You will highlight it better so that you can see the points that we're trying to make. And the only thing I can hope for is that we have an opportunity to sit down and go through it together, just so that you can see what we're talking about. And if there's anything else that you've received from CMS, we certainly would want to understand what issues or what the risks are. We don't want any issues with the Medicaid program. So, we certainly would be on your side. I think, so I represent Renowned Health. Renowned Health's largest payer for NICU care is Nevada Medicaid. We operate a 39-bed NICU unit. And when you look at this change that we're contemplating here, the results, the effective rate change, even though it's not a rate itself change, but the effective rate change of this policy change is about $4 million at Renowned Regional, which is almost double what the impact of the rate increase was back in 2019. So I just wanted to put that on the record. In addition, I do think it's super important for us to remember the issue that we are talking about today is an issue that we started kind of trying to debate and figure out back in 2010. Prior to 2010, NICU services were paid based on site of service. So, and the bottom line is those babies who are NICU level 2, 3, and 4 are all taken care of in the same unit. They're in the ICU, they're receiving different levels of ICU care, all of which is greater, as far as I understand, greater than 6 hours a day per baby. So to think that we could realign these revenue codes with clinical care for ICU level care, and think that a newborn plus rate would be adequate, a $400 rate. We added 25% to the newborn rate, which I completely understand, but no other payer that we have in this state pays 172, 173, or 174 other than at a NICU level rate. What we are talking about with 172 is a newborn rate. And so a newborn plus rate, I guess I should say. We struggled through the topics that we are struggling through today over about 3 or 4 years, which is how we came up with the Memo of Understanding of 2015 with the director of Medicaid and others at the table agreeing that we had aligned things. And just in the last couple of years, we ended up putting it in the manual. And so this recent manual change, this policy has been in effect for a number of years with the blessing of Medicaid for a number of years. And so I struggle with undoing it without us coming together and having you at least see and understand the elements that we debated and talked to your predecessors about for multiple years, with stacks of claims, with medical review, with copies of contracts that we would sit down individually to show you. It was a long process, and we thought we came out with a win-win. And if it doesn't work anymore, we'd like the opportunity to work with you on something that meets everybody's objectives and isn't so detrimental to just the provider side providing this high level care, because the result on the patient is the thing we should all be focused on. Those are my comments. Thank you.
Thank you again, Chris. And if I could just add into that, Chris, that I know one of the individuals that you guys worked very heavily with was our prior deputy administrator, Dwayne Young. And if I could just add that this policy update was at his direction prior to leaving. So, and then there was a meeting last week with where he joined us with some hospital staff members, where he reiterated why this, policy changes are being happened and kind of some of that history of it. So
yeah, I appreciate that, but Dwayne was not involved in the development of the policy in 2015. He was part of putting it in the MSN, but I believe he inherited it. And I'm not sure we ever got to sit down with Dwayne either and show the elements that we sat down with, your prior clinical, what is the name, physician leader. So is that your medical director and the director of Medicaid? And anyway, the list is long, but we'd be happy to do that and at least show you what we were trying to solve for, and maybe we could come to some intermediate conclusion. Sorry.
No, don't be sorry. We appreciate your comments and feedback, Chris. Thank you.
Chris,
and then, sorry, go ahead, Dr. Caprero.
Chris, if I could just say, we would welcome such a meeting. If you'd like to sit down with us, we're more than willing to do that. And I think you are correct. If you look at the legislative meetings, I don't know that there is any indication about the memo or any of the crosswalks that were put in place. Happy to come back with you and discuss this in greater detail.
Thank you.
So Chris, if you want to go ahead and send Dr. Caprero or myself some dates and time that work for you, we can get that set up. My recommendation would be the sooner the better, because at this point in time, the anticipation is to take this policy update to the November 30th public hearing, which leaves me a very small window in order to get that posted. So if you want to get us those dates and times as soon as you possibly can, we'll do our best to get something set up in the near future for that.
I appreciate that, and we'll identify a small group. We won't inundate you with everybody unless it's okay to bring our group. You let us know, but we'll find dates for you quickly.
Thank you for that. Did you have anything else, Dr. Caprero, or?
I just wanted to make mention that for the managed care organizations, we don't directly dictate or control their reimbursement rates. We set the floor for the rates, so they can't pay less than what our rates are, but they can always provide more. And we do have our managed care organizations, 4 of them now, that will be starting January 1st. I just wanted to make a note of that.
Thank you, Dr. Caprero. And seeing that we're just about out of time, we'll go ahead and, per the agenda, open it up to if anybody else has any public comment regarding any other issues outside of these proposed policy updates.
Sheila, we do have some in here in office. 1 second.
Dr. Caprero, this is Sarah Hunt from NHA. Respectfully, the new contract RFP that we saw did not contain language which we had recommended to the division that Medicaid was set as a floor. So
that's a standing policy, and I know our Deputy Administrator Cindy Rubald is also on the line. She can speak more to that RFP, but that is a standing policy that all of our rates and policies have to be followed by the MCOs.
Yeah, so this is Sandy Rublid. They can offer value-added services, and they negotiate their contracts with their providers. We don't get in the middle of that, but they are not allowed to reimburse lower than Medicaid. So I'm not sure what language, off the top of my head. I would have to do some research with the team, but that's always been the policy.
I appreciate that, Sandy.
This is Patrick Kelly again. I just want to thank you for the opportunity to present here today. Apparently, we believe there is a misalignment with the revenue codes, and that needs to be addressed. And we would like the opportunity to submit a letter to you outlining that and ask that it be made part of the official record of this meeting. But you know, one of the things we really hope you look at is that on this level 2, from taking it from $18.58 down to $408, $408 to take care of a baby for a day in a NICU unit is just ridiculously low. Even if you think we were upcoding, that level is just unacceptable. It's almost the same rate as a healthy newborn child, and that doesn't make any sense. So I think that we really need to take an overall view of this situation and come up with an equitable solution. And once again, thank you for your time today.
No, thank you for that, Mr. Kelly. And just to be clear, you know, our intention is not to indicate that anybody has been upcoding. It's just to ensure that we are properly reimbursing at the appropriate levels of care based on the, you know, with the revenue code based on the level of care. So again, to everybody out there, if you have information that contradicts how we've mapped it out, we are totally open to receiving that feedback and taking a look at it again, because we do want to ensure that we are properly reimbursing at the appropriate levels based on those services. So again, with that being said, with looking at going in the November hearing, the sooner you can get me that information, the better. So it gives us a chance to look over that and determine if we need to make any updates to this policy prior to going to public hearing. So we thank you all for your time today and your input, and appreciate all the feedback and comments. And I think I indicated earlier, my email is within the comment box on here. If not, Crystal Baselli is on the agenda and she can get me any information if you're on the phone and don't have access to that. And thank you all for joining today. I hope you have a great evening. Thank you.